Okay.
Are you live? Okay, here we go. Go live. All right. We're live. You're
All
live.
right.
I'm live, I think.
Think we're good.
Okay.
Welcome, everybody.
Yay.
See here. Double check. Right. Mm-hmm. All right. Cool. Yep. Good.
Hey.
Hello, everyone. It's Dr. VanderWel, Dr. Tan. We are here, and we are going to discuss some myths around weight loss surgery, medication, whatever you guys would like to discuss. If you have questions related to any of these things, love to hear from you in the chat. And yeah, last couple weeks ago when we did this, I think we got through like a third of the things of our top points already. So it was yeah. So welcome to join in. So without further ado, Dr. Tan, if there's any questions, maybe. do we have any pre-prepared questions or requests? Otherwise,
people really like busting myths or having us try to bust myths because we got quite a few kind of things for us to talk through. Last week we talked a little bit about, bariatric surgery. Is it a cosmetic surgery? We talked about risks of bariatric surgery last week, it looks like. And then we talked a little bit about like stomach stretching too last week, which was good. Or not last week, but 2 weeks ago when we did this. But maybe we can go through what some of the folks sent in, which some of them are common ones that we were planning to talk about anyway. So let's start with a big one. You can't drink from a straw after bariatric surgery. What are your
good question?
What are your thoughts about straws?
I'm ambivalent about straws, honestly.
Okay.
I think of all the things that are going to be the detriment to you, even immediately post-op, I don't think a straw is a big one.
Yeah.
If you gulp a bunch of air when you drink a straw, that's a problem. If you sit there and guzzle down things after with a straw, then that's a problem. But otherwise, if you just go in a small amount, I think you should practice like what does a half an ounce feel like to drink at a time. You should feel like how much of a swallow that feels like. You should try to go to 2 ounces and be like, work your way up to 2 ounces before surgery and be like, okay, 2 ounces feels like this. So that like when you take a drink of a straw, like for me, usually like an ounce is like two, a couple of like medium little swallows. So yeah, I think it's just I don't have a big problem with straws though. So
yeah, I've actually done like I've tried to do deep dives on this before because like I think like through training, when we first learned about bariatric surgery, everyone teaches you no straws. And it's always been a little bit unclear to me why. Like I know it's the swallowing air thing, but even mechanically, it doesn't make sense to me why a straw would introduce more air than just drinking, regularly. And so I've like tried to find actual physical like data or like an experiment. And there's nothing out there. It's kind of one of those like just I think it's been perpetuated in time about like straws being a concerning thing after surgery. But I do think just like using a straw myself, I can drink faster with a straw. And it's a little bit easier to drink faster with the straw. So it is just the pacing that you sometimes can maybe like lose track of with the straw, if anything. I think our like protocol is just out of an overabundance of caution, no straws for the first month. And then after that, I tell folks it's fine for you to try using a straw. And if it doesn't irritate things and you're not drinking too quickly, then it's fine. But it's one of those things that you hear over and over and over again. People are like, I can't use my straws anymore. And I personally like drinking through a straw. So
Yeah, I don't have any problem with people drinking through a straw.
Yeah,
So.
yeah. So anyways.
Excellent question from Ectezo. Thank you for your submission. Can you twerk after surgery? So I would say, interestingly, I've had a number of patients that have on their, after surgery, you're not going to really feel like a lot of twerking. But sometimes on the preoperative EGD, I've had a number of patients get up and try to twerk on the stretcher. So,
oh, jeez. That's a funny
next
one.
question.
Yeah. Well, going off of that though, activities after surgery, I think that's a pretty common one. Like when can you restart doing X, Y, and Z after surgery? No heavy lifting is probably the only like absolute thing that I have for my patients for the first few weeks after surgery. And that's mostly to protect your incisions, prevent you from developing hernias while they're still healing. Every other activity that kind of spares your abdominal wall muscles is fine in my book, as long as it doesn't hurt you. And that includes aerobic activities, cardio, all of those things.
My general guidelines are 60 fluid ounces, 60 grams of protein, and you're feeling good.
Yeah. Yeah.
When you hit those metrics, you're ready to just get into it. I too tell people start at about 50% of what you were doing before.
When the weightlifting restrictions are up. Yeah. So, all right. So I don't know, twerking, I don't know how much abdominal wall muscles you're using with that.
Yeah, it's not gonna feel very good at first.
I'd be
Those
pushing
incisions after a laparoscopic surgery, those incisions, they're gonna feel kind of like a pulled muscle. And so if you're doing a lot of gyrations, then I think that's gonna not feel that great, on your abdominal wall. But if you just ease into it, then I think you'll be fine.
I have two related statements, maybe. One is I thought I'd lose weight really fast after my Roux-en-Y gastric bypass. And the other question is, once at the 1 year, or the statement is, once at the 1 year mark post-op, you don't lose any more weight. So I think these are all questions about just like pacing of weight loss after surgery and what to expect. What I usually tell my patients is that this first month you lose weight rapidly. That happens with most folks. It's almost alarming for some people how quickly they lose weight in that first month. You're losing a lot of water weight initially. And then you're on such a low calorie diet that weight loss just happens again super quickly. A lot of it's water. And then after that first month, things tend to stall or slow down pretty significantly. And then the pacing of the weight loss tends to be a bit slower moving forward after that. And it's never, I would say, like, rarely is the weight loss like linear for folks either. It tends to kind of like lose weight. You might stall for a little bit, lose weight, stall a little bit. Everyone's a little different. And then I think just overall timing of weight loss, typically 12 to 18 months is what I quote folks. That's kind of where you'll probably get to your lowest weight during that time period. Some people get there a little bit earlier. But is it impossible to lose weight after a year or a year and a half? No, that's also not.
No, weight loss is a journey, and it's a lifelong journey. Weight management is a lifelong journey for everybody. Oh, yeah. Quick question to interrupt those double question statement / flasher. Everyday Trey, can you detail the endoscopic sleeve gastroplasty procedure, the ESG? Yeah, great. Thanks for the question, Trey. Happy to. So, I could probably do a little show and tell here, actually.
Ooh. Yeah. You have the most props, I feel like.
Always. Yep. So the endoscopic sleeve gastroplasty is a pretty cool procedure. It's technically non-surgical. You use an endoscope that goes down through your mouth with a suturing device. This is attached onto the scope. You can see this thing right here. Let's see if I can get out of the way. This thing, what it does, essentially it's a suturing device that passes suture back and forth. And what you do is you can take your stomach, which is this big bag right down in there, and which is made to contain a lot of food and make you hungry and want to eat a lot of food. And you take that bag and you can take suture bites in there and you can crumple it down into a smaller tube and to make it much smaller. having a smaller stomach is a huge benefit for weight loss. And it's very helpful to have a much smaller stomach. That's what the laparoscopic sleeve does. The endoscopic sleeve does that just with a different way. You don't remove any of the stomach. There's no incisions. You just crumple it down. You sort of sculpt it from the inside with sutures. I've been doing this procedure now for 5 years. Dr. Tan, you've been doing it for almost a year. And it's a really cool procedure. I think it has a lot of benefit for a lot of patients. It is, in our practice, we usually see somewhere around our average is low 20s, 23, 24% total body weight loss. Some people do better. Some people don't do as good. But it can be a really, really great, life-changing procedure for people. And it's very helpful. There are celebrities that I'm sure that anyone watching this would know who have had endoscopic sleeves done. And also do, I think the endoscopic sleeve plus the new GLP-1 medications today is a very, very interesting, very, very cool concept, very, very cool, procedure combo. And we've been doing this procedure for a long time. We have a lot of experience with it. We have some of the best results that are out there. Actually just got back from training the people in Canada. There's a number of surgeons in Canada that are adopting this and they're getting there going. So we were doing some of the first cases in Canada. So that was cool. And off to a great start. There's people all over the country, all over the world that have been doing this procedure for a long time, tens and tens of thousands of these cases now. It's a very cool procedure. If you're really interested in it, check out our website, Aviva MD. You can see more stuff about it. You can reach out to our team, ask some more questions about it if you want. Always happy to talk to people about it as well. So,
yeah, I'll just add on. You're the expert in the ESG, but it's probably the procedure that most people haven't heard of when they come to us. It's a little bit unique. There's not a lot of places that offer the ESG, and so I usually have to introduce it as a totally new procedure to most folks who have some familiarity with like the lap sleeve and the bypass already. And did you mention, so to all the people listening, Dr. VanderWel is like a national expert on ESG at this point. And you probably do more than anyone on the West Coast, honestly, right?
I think it's pretty close.
Yeah, I know there's some people on the East Coast doing them a lot, or and some people in the South, but and you just did the first Canadian ESG, no? Or you?
It wasn't technically the first Canadian. I did the first ESG in the Canadian health system with I was there helping them get their program started. I wasn't personally doing it. I was taking them through it, kind of helping them out. It's always a little scary when you first start doing a new procedure. It's its own beast. Yeah. So
cool. Pretty cool.
No, it was great. It's a great experience. I think it's gonna be cool. It's be a great tool for a lot of people. A lot of people all over the world that are just, they're looking for help. And it's really helpful to have a smaller stomach. And the surgeries aren't for everybody. I know like we do a fraction of a percentage of people that are eligible, because most people feel uncomfortable with the idea of surgery, and I respect that. And that's why there's more things that we do. We have endoscopic sleeves, we have medications, So it's weight loss is tough. It's really tricky, and we just need as many tools as we can to fight. So,
yeah.
Thanks for the question, Dre.
All right. Let's move on. Get through more of these. Let's see here. Kind of related to the straw one in my mind, but we should probably just bang all these out. You can never have carbonated beverages after surgery again. Ooh, what's your thought?
What are your thoughts on that?
I tell people no, nothing is 100% off limits after bariatric surgery. If you had a bypass, smoking is 100% off limits. But apart from that, nothing is 100% off limits after bariatric surgery. Carbonated drinks, they're going to fill your stomach because of all the gas bubbles. And those gas bubbles tend to be a little irritating. And so I would approach with caution and just know that anything carbonated that you drink after surgery is, even if you can tolerate it, it's going to be a little bit detrimental to you getting your overall goals met, right? Your hydration goals met, your protein goals met, because you're just filling your stomach a little artificially with the carbonation. But if you're looking at it as kind of an every once in a while treat, then that's fine. You probably shouldn't be hydrating yourself 100% off of like sodas and stuff. But
yeah.
This
is the carbonation is one of the few things I tell people, like, you should really probably just let that one go.
You say no forever.
I don't say no forever and zero, but I just say, like, hey, if you can just get away from that, like, you will, it's going to be such a benefit, because those bubbles, they do some, stretch things out. And if it's uncomfortable, then that's bad. It's a bad sign usually that you're stretching things on the inside. The other thing that I think, I kind of tell people, like, hey, like, if you have something with carbonated beverage in it at some point, like, if you just open it up and let it go as flat as you can first, and try not to drink it at max, bite, if you will, that's helpful. But if it's feeling uncomfortable in there, then it's generally stretching things out.
Yeah. That's definitely, for sure. I would say out of, between straws and carbonation is probably it's probably more concerning in a lot of ways than straws. But general rule of thumb, if it's uncomfortable, that's because your stomach is getting stretched. And we don't really want that to be happening.
Yep. Had another good question from Trey. This is a good one. I didn't hit on this. What's the average downtime after having the endoscopic sleeve? So average downtime is usually like 2 to 4 days. And what the experience like is usually you feel kind of like you have a stomach bug. That's my best description of it. I ask people after surgery, like a laparoscopic surgery, like, how does it feel? It's like, it hurts. It doesn't feel good. Like right here, right there. It's like, because it's got incision and incision discomfort. The endoscopic sleeve, there's no incisions, but your stomach is, it's crumpled down and it's tied down. It's, for lack of a better term, it's tied in a knot. And what people describe is it just kind of feels like a stomach bug for about 2 to 4 days, where you're just like, I feel kind of blah, like a little queasy in there or something. And usually you get your medication to get you through that. And then when I see people at their 1 week post-op visit, they're like, yep, I'm good to go. And it's weird. It's really interesting. You're like, you wake up one morning of 2 to 4 days, and you're like, oh, I'm good. I feel like somebody like opened the window in here, and I can get on with my life. And here we go. We're just going to do, we're going to be doing liquids for a week. In our program, we do liquids for a week after surgery, 7 to 10 days. Then you move on to purees for about a week to 2 weeks. Then you move on to soft foods. So soft foods being like chicken or fish or stuff that's really, mushable with your fork. And then portion size is just a quarter cup. It's very small. And after that is moving on to regular textures. What's really cool about having a smaller stomach is that, people try, the key to weight loss is really generally eating less calories. The way to do it the best and the healthiest is to eat healthy food in small portions, so you don't, feel like you're being too deprived. The problem is that it's just so hard for it to do that. Your body does not think that obesity is a problem. Your body thinks that like winter and famine is a problem. And so it's trying to keep as much calories as it possibly can. So what's cool is after your stomach gets smaller is that your body's just like, oh yeah, we're cool. Less calories. That's fine. We got stuff in the storage unit now. And it just seems to make these changes inside your body that are really helpful for making some progress on your weight. So, generally when people are like, they're generally getting honestly back to exercise by 7 to 10 days for most of my endoscopic sleeves. And the nice thing about the endoscopic sleeve is because there's no incisions, you can actually get back to twerking if you want to, there you go. But but like seriously, like you can do more exercise because there's no incisions that you're worried about healing. You're not going to be able, like, it's going to be really hard to hurt those sutures from the outside. If you push them from the inside too much, like if you eat a big meal of regular hard food, like you can radially stress them from the inside of the sutures. And that's definitely something we want to avoid. But the other part of it is just that, it's going to be fun. Yeah. So I got some more questions coming in on the Instagram here.
Okay. Before we go on, I just have a comment. Kathy, who I believe had an ESG with you, says best decision I have ever made. 2 years in maintenance. Congrats, Kathy.
Yeah, Kathy. Go girl. Yeah, Kathy's great. Rocking it. It's cool. Yeah, I think that's the best part about being a bariatric surgeon is that you have there's so many wonderful stories we get to be a part of every day.
A lot of things to celebrate. It's fun.
There really are. And it's not always like it doesn't always perfect. It's the path isn't always smooth and clear. And is it, all your dreams and come together with rainbows and butterflies and unicorns? Of course not. Like that's not real life, but it's a journey and we get to be there for people and help them make their lives better. And no matter where they are, we're going to support them and be there for them. And that's what's cool. That's what's really cool. So, and just these tools work really well too. Like they're good. They're good. They really help. So, thank you, Kathy, for that comment. Jody RT. If a patient has a hiatal hernia, is this something you can also address? Absolutely, Jody. We do lots of hiatal hernia repairs. Personally, also something we do in our practice is do hiatal hernia repairs and Hill repairs, which is not a super commonly add-on, little procedure done, but it does. Been doing this. I've been doing this personally for almost a couple of years now, which is not a long period of time. I'm going to say this right now in the anti-reflux, so like hiatal hernias returning recurrence zone, but absolutely I'm seeing a big benefit in having less hiatal hernia recurrences. So what it does, the Hill does is also what a hiatal hernia is, let's just as a description here. So you have your diaphragm is that muscle that separates your chest and your abdomen, and your esophagus connects your mouth to your stomach on the inside, and it goes through your diaphragm. And what's going to happen is that you have to have a hole there in your diaphragm so your esophagus can go through it. But if that hole is too large, your esophagus and your stomach can actually creep up through there. And so it starts coming up, and that can be a cause of heartburn, because of discomfort, because of swallowing issues. And so at the time of a surgery, like a laparoscopic sleeve or a gastric bypass, we can actually fix that, bring the stomach down into the abdomen where it's supposed to be, tighten up and snug up that diaphragm with sutures and suture it closed. And then actually do another repair where we put another additional stitch in there where it actually will fix it almost into the, kind of transfix it down at the base of the hernia repair to give it the best chance of not recurring and having the best amount of weight loss and heartburn resolution. So, yep, absolutely something we can do, and something we do probably multiple times every week. So,
yeah, I'll add, I mean, every patient that I do surgery on, I actually have to teach a lot of them what hiatal hernias are, because it's a little bit of an unusual hernia. And if it's a big enough hernia, you actually have to fix the hiatal hernia before you proceed with your bariatric surgery. Because part of the mechanics is if it's big enough, your stomach will slip into your chest. And we actually need that stomach down in your abdomen in order for us to do your surgery. So sometimes you just have to do it. There's kind of no choice. Most people don't know that they have a hernia either.
Yeah, it's true. Yeah, a good amount of people.
Yeah.
Good. Yeah, good point. Carlitos, you guys are the best. Bless you. You're the man, Carlos. All right, and then Robert, another great contributor. Since nothing's actually being removed, does ESG result in the same ghrelin reduction as the lap sleeve? Just curious how ESG affects hunger cravings. Excellent question. So ghrelin is a hormone that we believe to be implicated in having how much hunger people experience. And this is a very interesting hormone. And we kind of think predominantly that the top of the stomach, the fundus is what that's called, this little sort of bulbish reservoir up there, is where many of the cells live that contribute and dump in ghrelin hormone into the body. I'll say that this is not the only place. There's lots of different places within your GI tract, particularly that excrete ghrelin and make you feel hungry. The endoscopic sleeve. So when I do my endoscopic sleeve, I'm pretty aggressive. I close as much of that fundus down as possible. I kind of try to get this. I keep going until I can't physically possibly close any more stomach. Usually I get almost all of it, except for probably maybe less than a grape size is usually the amount of stomach that's left there. So we have a pretty aggressive endoscopic sleeve. That may be why we get some of the better data, from some of the better results with our endoscopic sleeve. Some people don't. It's a little bit it's more challenging technically to get up there and close that part. There's a little bit more risk because there's, other organs in there. The endoscopic sleeve is generally a very safe procedure. But there is, generally when people get in trouble, it's when they get in trouble up there. Knock on wood, we haven't had that. What I would say from a ghrelin standpoint is that ghrelin doesn't seem to be as reduced compared to like a laparoscopic sleeve. From a patient experience standpoint, I'll give you a demonstration. Like when I ask people, so after your laparoscopic sleeve, what is it like? Most patients say, when discussing like fullness / restriction versus hunger, they're like, I'm just a lot less hungry than I was before. And that part's really, really curbed down. I got to sort of remind myself to eat sometimes. That's not true for everybody, but I would say generally that's the experience for many people. And then they're like, yeah, I'm sort of full. Like if it's been a couple hours, they're like, I wouldn't say that I'm full still. Like that's not like a thing that they generally say. The endoscopic sleeve people, they say a little bit of the opposite of both of those. I would say the first thing they don't say is, oh, I'm just not hungry anymore. Some people certainly do still, but I would say that's not where like its strength is generally like when people are like, hey, it's like been a couple of hours after a meal. Like, am I kind of hungry? Maybe. Yeah, sort of, maybe. But am I feeling still kind of full? I would say, yeah. They're like, I feel full. That's the first thing that generally comes out of their mouth is, yeah, I just feel more full, as opposed to I feel less hungry. And this is kind of a nuanced, weird thing. This is where a lot of weight loss lives, is inside of this tension between a lot of different factors inside of your body. There's a lot of different things that go on. It's very, very, weight loss is complicated. Your body's management and just attraction and desire to eat food is extremely redundant. It's extremely robust. That is the reason that people have survived for all of history, is because they have desired food and has compelled them to do very significant, very difficult actions. So what we do, we still see when people have tested this, they still see a reduction in ghrelin with the endoscopic sleeve, just probably not to the extent that we see with the laparoscopic sleeve. Interestingly, laparoscopic sleeve ghrelin reduction certainly goes down, but it does seem to slowly kind of increase a little bit over time as well for any bariatric surgery, just not generally to the level that it was was before surgery. So, good question.
Yeah,
very interesting question.
Yeah, ghrelin is an interesting. I feel like ghrelin has made its rounds on the internet because I have patients ask about ghrelin pretty commonly, and it's definitely a real thing. But I don't over read into ghrelin levels too much. It does explain why hunger pretty much goes away immediately after your sleeve gastrectomy. But like you said, that hunger can come back because there's dozens of other hormones that are in your body that are not removed during the sleeve gastrectomy that regulate your hunger. So of course your body's going to compensate and start having some hunger again. And so it's definitely not necessarily a permanent thing. For some folks, it is pretty like they never really feel hunger again after their sleeve, but it's also very normal to start feeling some hunger cues afterwards. But it's part of the mechanism of the sleeve, right? But also just because the endoscopic sleeve doesn't decrease ghrelin as much, I also, the bypass actually doesn't increase your ghrelin very much either. Because a lot of that stomach is still there, but the bypass is still an incredibly effective procedure. So it's complicated. There's so many hormones.
It's very complicated. It's very interesting. And this is where I generally encourage people to, weight loss is so hard and your body is so resilient at wanting to pursue calories and storing them and holding on to them and being very efficient with them. I generally encourage people to be as aggressive as you can about stuff because it's hard. It's really hard. And, it never gets easier as you get older to manage your weight, unless you're like 17. And I would say in 5 years, your head will probably be on a little bit better. For most 17-year-olds, I think myself, certainly included when I was 17, I had a little bit better concept about how to, live my life when I was 5 years older than that. But, yeah. So.
Okay. Oh, and then one other, and this might be getting too technical.
Carlos said ESG 5 months ago. He's down 90 pounds. Right on, Carlos.
Oh, good.
My man. Yep. So.
ESG folks, that's awesome. All right. Okay. Are we ready for another myth or statement?
Ready? Let's do it.
Let's just keep doing all the fluids. Caffeine. Is caffeine dangerous after surgery?
Ooh, what do you think about this one?
So caffeine is this is uh this is a hard one for folks, and I understand why, because it would probably be the hardest thing for me as well. So we do tell folks to stop drinking coffee before surgery, and then to stay off coffee after surgery for a period of time, or just caffeine in general. I think there are some misconceptions in my mind about why we do that. Caffeine, for one, it's not incredibly hydrating. It is a diuretic. So when you have limited volume in your stomach, it is not the most, we want the most hydrating fluid for you. And so caffeine is just generally not going to be the best thing there. But also the caffeine can be a little irritating to the stomach early on after surgery as well. Another reason why we kind of want you to stay off of that. The reason why I usually tell my patients to start weaning off coffee like several weeks before surgery, for me, it actually, the caffeine doesn't change anything the day of your surgery. But if you're like me and I stop coffee, all of a sudden you get these rebound headaches that are awful. And you don't want that happening when you're also recovering from your surgery at the same time. So it's best if we just kind of get you through that caffeine withdrawal first, do surgery, and then you can just focus on your recovery there as well. But long term, fine to have some coffee in my mind.
Yep.
Yeah.
Yeah, it's not an evil thing. I would agree.
I will. Go ahead.
Go ahead.
I will say one thing to be mindful about when it comes to coffee is that there are a lot of ways to make coffee more delicious than just black coffee. And so you have to be very, very careful about all the things that get added to your coffee. Because that's another, so many
pitfall.
times folks have
Major
been like,
pitfall.
yeah, they're just used to what they're drinking, and then they don't realize that their coffee drink that they've been ordering forever is like 300, 400 calories. You know, it really adds up. It's kind of wild. So you do have to be careful with the coffee sometimes with that.
The one thing I like to say about the coffee thing is this is a lesson I've learned several times seeing patients that, there's obesity, especially when you treat obesity, there's just an element of like all of us have to use ways of coping, in our lives. And for a lot of people that struggle with obesity, food's a cope. It helps them cope. But there's other copes too that we all have. There's caffeine, there's nicotine, there's, drugs, there's alcohol. Like all these things are, can be pretty significant. Maybe even crutch is a strong word. Like maybe it's a little bit overly, but for lack of a better word, that's a piece of one of these things that they like lean on really heavily. And they feel like they almost incorporate it into their identity. What's really interesting about the period of a weight loss procedure time, like after an endoscopic sleeve or laparoscopic sleeve or a gastric bypass, is it gives you this, it's kind of a big moment in your life where you're like, hey, I'm really taking a direction, a change in direction almost. It's almost like a health baptism. And like what this is a great opportunity for, honestly, is to reevaluate some of your relationships with your copes. So particularly alcohol, caffeine, THC, like marijuana, like some of these things, if you can go off of them for a period of time and you get clean from them we try to really recommend people be clean from them for like 6 weeks, not necessarily the alcohol one, but even then, especially if someone's drinking lots of alcohol, like, hey, we really want to cut this down. I've had a lot of patients that have gotten off alcohol, but let's go caffeine, right? They've been off caffeine for 6 weeks around surgery, like we asked them to. And afterwards, they're just like, wow, I just feel cleaner. I feel like I'm more like almost intentional. Like I feel like I'm not depending on this substance to kind of keep me going throughout the day. They're really thankful for that time, that hiatus, and that time away, and they've kind of readjusted some things in their life for a different season. And I think I like to give people the space to say, hey, this can be a part of that story. And, maybe, I don't know, but without sounding too like, ridiculous or something, but it's like, hey, you should maybe think about having some space in there for letting you grow a little bit in this regard and giving you a chance to grow, which is what the coolest part about these procedures. It's not just that you get healthier and that you weigh less. It's just that you can take so many cool different steps in your life forward. So
Yeah, you take it as kind of a jumping off point. Yeah.
Yeah.
And then, good things beget good things. So, yeah. And the other thing, just from a coffee standpoint or caffeine standpoint, if you're drinking a lot of caffeine and it's impacting your sleep, that's the other thing to be mindful of as well. Because good sleep is really important for weight loss too, which I don't think we talk about enough.
Absolutely.
Or we just kind of, I know I don't talk about it enough with my patients. So, all right. Let's see here. Nicole says protein coffees are her jam, which I
not bad.
If you haven't tried a protein coffee, that's a great way to get in your protein and your caffeine together, and still get that sweetness and that kind of like fun treat feeling.
Yeah, it's almost like you can do like a mocha, or get like coffee and put like your chocolate protein shake in it.
The recipes, there's so many. I mean, there's a lot of
not a good stuff.
I'm kind of boring. I just drink. I add a little bit of creamer or something, but it's fun for me to hear other people's coffee orders. I don't know why. It's one of those things.
I find it kind of tiring. I'm like, man, this is complicated. Like, I just do black coffee.
I don't know. It's kind of fun for me. I'm like, what? Then you add what? All right. Let's see. I think that is all the stuff that was sent in beforehand. Do medication dosages for drugs need adjusting after surgery for Roux-en-Y patients or I guess just bariatric patients in general?
I would say rarely in my experience. Levothyroxine, generally as you lose weight, most people don't need as much thyroid. Many people, I'm not going to say everybody, many people don't need as much thyroid medication or can't even come off thyroid medication. Lithium is the one psychoactive drug I find that we want to make sure we regulate. We watch that level pretty closely. Number one, its therapeutic range is small, and it does seem to have more of an absorption effect, particularly if you've had a bypass. The rest of the stuff, I don't really see a huge difference with stuff. Yep.
Yeah, it's there's a lot of hemming and hawing, I feel, about like drug dosing changes before and after surgery. And I think the reality is, for the most part, we just don't know. Honestly, the dosages that we have right now are pretty much all the studies are based off of typically normal weight folks, like folks in a normal BMI range, and not focused on folks who have excess weight. So something to keep an eye on in terms of efficacy and stuff. Like if some of your like psychiatric medications don't feel like they're as effective, or they feel like you're having more side effects or something like that, definitely something where you might want to look at adjusting. Thyroid, that's another big one too, that'll change potentially. But
some medications change just with losing weight, like you said. But I would say from an absorption standpoint of affecting absorption, the endoscopic sleeve I see so rarely affects absorption at all of anything. The laparoscopic sleeve, also very rare. The bypass does have some, that's a piece of that surgery is malabsorption. And so there's an element of that we do want to be mindful of, and we watch that a little bit more carefully. Also, that's what gets the finger shaking with the vitamins. Because you got to make sure you're getting that stuff in going.
Got to take your vitamins, yeah.
Especially in the early 6 months when, your calories are so low. Like as an example, what's so crazy about these procedures is that usually your body all of a sudden is just like totally cool with 450 to 650, 700 calories a day, for long periods of time, like months on end. And that's just not very much. And so to really make sure that you have all the little chemistry pieces that your body needs, you want to make sure you're taking some good vitamins. And especially if you have a bypass and your absorption of said vitamins is, quasi compromised, you got to make sure you're on that one. So
definitely take your vitamins. All right. Let's
Uh-huh.
do another potential misconception. Insurance will not cover bariatric surgery.
This is
And this is
this is
often
surprising how big of a misconception this is. I actually saw a patient a couple weeks ago who almost went to Mexico even when she had insurance coverage because she didn't realize she had insurance coverage. Yeah.
really.
Yeah. She almost cash
Wow.
paid and went to Mexico to cash pay. And then she just like randomly checked her insurance. Like, wait, I got insurance coverage for this procedure. And I think it's like 40 something, almost 50% of people in Washington state have insurance coverage benefits.
Really? 40%, you think?
It's at least 30 to it's at least 30. It's at least
Okay.
somewhere in the high 30s, but I'm pretty sure it's in the 40s.
Okay. All right. Yeah. I mean, yeah, this is a myth. Insurance does cover. I think this is usually followed by insurance does not cover bariatric surgery because it's cosmetic or it's, it's for weight loss, etc. But not all insurances cover bariatric surgery. This is true, unfortunately. But if you don't know, you should definitely check in. Especially if you're thinking about going to Mexico or, paying for it out of pocket. Definitely check your insurance.
This is a good question. So the thing that you want to check with this is you got to make sure that whoever you get your insurance from has the insurance benefit. Because just because you have say Premera or Blue Cross Blue Shield, and someone that got weight loss surgery with that name, that company's insurance, doesn't necessarily mean that where you get your insurance has the benefit along with it. You have to actually usually select in for that one.
Yeah.
And so you have to, it's complicated. They kind of make it complicated, honestly, but it's something you just got to look into. And then honestly, if you don't have weight loss surgery benefits, first of all, I know it sucks. It's a big gut punch, but take a deep breath. Number one, your employer might actually have a plan that has weight loss surgery benefits. So you can actually just switch to that one at open enrollment time. That's pretty common with a bunch of the Washington State employees, some of the Boeing plans, some of the Amazon plans. There are plans that have weight loss surgery benefits, and there are plans that don't. And so it's just kind of knowing what your options are, even just for your employer. And then there's always, I have some people that have looked into. They're like, hey, I was kind of thinking about switching jobs anyway. And so that's something to think about. And then there's always self-pay too. So we try to make sure our self-pay rates are really affordable. It's way cheaper than getting your bathroom remodeled, and it can potentially save your life.
Yeah. And I should probably know more about insurance, but I don't. I've just given up on trying to understand how insurance works in general.
It changes so frequently. It's hard to stay up on top of it.
Yeah. So if there's any question, I feel like the foolproof way is reach out. Our program does free, we'll do an insurance check for you if you would like, and we will check into that again for you and figure out whether or not you have insurance. So that will cover bariatric surgery. And then oftentimes, we have folks who can kind of guide you if your work plan does have a bariatric surgery option that you can opt into.
Robert just said exactly that. Insurance covered my procedure, but there were a lot of hoops to jump through. And I was really grateful that Aviva has coordinators to help navigate the bureaucracy.
Exactly.
Indeed.
Yeah.
Indeed. Couldn't have said it better myself, Robert.
Exactly. It's don't try to just do it alone either. It's confusing.
They make it confusing on purpose.
Exactly. Yeah. So that's why we have experts who can help you through that.
Yeah. Yep. It's very little. Our people are really good at this. They're really efficient at it. And they will help you get through this murky spot very easily. Whereas you trying to do it yourself is really challenging. So
it shouldn't be that way, but it is that way. And so you're not alone if you're confused. We all are.
Mm-hmm. And we're starting to get the process of trying to get some endoscopic sleeve gastroplasties covered by insurance too, which is a very exciting development. It's happening more and more around the country. We're starting to get picked up too. So if you're interested in that, there's potential we can try to get that part rolling too. So
yeah, more and more coverage, hopefully.
Yep. Absolutely.
All right.
2025 is going to be interesting. The drugs, the medications, the GLP-1s, they're so expensive that insurance companies, we're already seeing across the country, are telling people like, hey, you should go to, they're making surgery easier and the medication's harder to get. Yeah. Like I heard like they might start doing supervised diets to start the medications. Yeah. And taking away some of the restrictions.
Like you have to do a supervised diet first and then do medications.
Yeah.
I guess.
Well,
I mean,
no. A supervised diet before they approve before you get the prior auth for it. Yeah. Well, because a very high percentage of people on GLP-1s actually don't even make it through the first 4 months. It's like 30-40%. And so if you're paying $1,500, $1,200 a month for that, you drop $3-4 grand, $5 grand, and the patient doesn't get any benefit from it. And because they don't go through with the therapy long enough.
Complicated stuff, you know.
It's an interesting time. All right. Well, do we have any other questions? If you have any other questions, thank you all for all your comments and for the engagement in the chats. We hope you all have a wonderful holiday. And I know this is a busy time of year for everybody. And so we really appreciate you guys tuning in and just, appreciate the love from all the patients. And this is why we do it. We love taking care of people. We love helping people and being there for them, and this is a hard journey. Weight takes so much away from people. So if you're out there, you're struggling, know that you're not alone. There's, we've helped almost 10,000 people now, exactly in your shoes, just with this journey. So we're here for you. And yeah. And someone said, a special thanks to the person who can you twerk after surgery. Yeah. That was a legendary one. So, all right, everybody. Have a great holiday. And thank you for tuning in.
Yeah. All right. Bye.
Have a great day.